Welcome to The Explainer. Today, we are taking a deep clinical dive into the brand new 2025 Gold Report for COPD. And let me tell you, this isn't just some minor update. We're talking about the global blueprint for how we diagnose, assess, and treat one of the world's most debilitating lung diseases. We're going to break down the key changes and exactly what they mean for you and your clinical practice. Let's start with just one number, but it's a big one, 3.23 million. That's how many people died from chronic obstructive pulmonary disease, COPD, back in 2019 alone. That makes it the third leading cause of death on the entire planet. This isn't just a statistic, it is a global health crisis, and it's one every single clinician needs to understand inside and out. So, here's how we're going to tackle this. We're going to follow the logical path of a clinical encounter. We'll kick things off with the sheer scale of the problem, then we'll get into the biology of the damage. After that, we'll do a deep dive on diagnosis, talk about the risks, and finally, we'll unpack that all-important step-by-step treatment plan. Okay, let's jump right in and lay our foundation. What exactly is COPD according to these brand new 2025 guidelines? Because, the definition itself has actually evolved to be a lot more precise and a lot more inclusive.
So, what are we really talking about here? The official GOLD definition you see here is absolutely key. And I want you to focus on that first word, heterogeneous. It's so important because it tells us that COPD isn't just one single thing. It's really a catch-all term for conditions ranging from airway abnormalities, like in chronic bronchitis, to the actual destruction of the air sacs themselves, which you see in emphysema. But they all lead to one single defining problem: persistent, irreversible airflow obstruction.
Now, you're probably thinking smoking, right? And you're not wrong. Especially in high-income countries, it's still the #1 risk factor. But, and this is a big but, it is far from the only cause. In huge parts of the world, it's indoor air pollution from things like biomass fuels that's the main driver. Then you've got occupational exposures, events from early in life that mess with lung development, and of course, specific genetic issues like alpha-1 antitrypsin deficiency. The bottom line is it's a complex dance between our genes and our environment that plays out over a whole lifetime. Okay, so we know what causes it, but what's actually happening inside the lungs on a biological level? Let's take a look under the hood and see how exposure to all these things translates into the disease we see in our patients. At its heart, COPD is really this vicious, destructive cycle. Think about it. Inhaled irritants, they trigger chronic inflammation. And this isn't your normal, helpful inflammation. It brings in cells that start dumping out these powerful enzymes called proteases. Now, in a healthy lung, we've got anti-proteases to keep everything in check. But in COPD, the system just gets totally overwhelmed. The proteases run wild and start chewing up the lung structural bits like elastin. And that leads to scarring in the airways and the total destruction of the air sacs, which is the classic sign of emphysema. All right, let's slow down a bit here. We're moving into our first deep dive, diagnosis. This is where a doctor's suspicion meets cold, hard evidence. And it is a process that absolutely demands precision and a very clear step-by-step approach. So picture this. A patient walks into your clinic. They're short of breath, they've had a cough for years, maybe bringing up some phlegm. And yeah, they've got a history of smoking. So how do we prove it's COPD and not something else, like asthma or even heart failure? Well, the process is very methodical, and it follows a really clear evidence-based path. GOLD lays this out beautifully in a 3-step process. Super logical. Step 1, you suspect it. You see the classic symptoms, you see the risk factors, and the light bulb goes off. But suspicion is not enough. That brings us to step 2. You have to confirm it. And this part is non-negotiable. It requires a specific lung function test called spirometry. It's only after you've confirmed the diagnosis that you can move to step 3, which is all about assessing the disease's real impact on the patient so you can figure out the right treatment. Okay, this right here, this is the magic number. The absolute key to a definitive diagnosis. We use spirometry to measure 2 things. The FEV1, that's the amount of air you can force out in 1 second, and the FVC, which is the total amount of air you can breathe out. But the crucial part is, we do this after we give the patient a puff of a bronchodilator. Why? Because we have to prove the obstruction is fixed and not reversible, like in asthma. So if that FEV1 to FVC ratio stays below 0.7, even after we've opened the airways as much as possible, boom. That's a persistent airflow limitation. That's COPD. Now, this quote on the slide, this is one of the biggest philosophical shifts in how we think about COPD. For decades, everything was about the FEV1 number. But what Gold makes crystal clear is that once you've made the diagnosis, that number actually doesn't tell you very much about how breathless your patient feels or how likely they are to have a serious flare-up. And that's exactly why we've moved to a much more holistic, patient-centered way of assessing them.
So if FEV1 isn't the whole story, what is? Well, it's this, the ABE assessment tool. This is how we figure out the right therapy. We group patients based on two really simple things: how bad their symptoms are, which we measure with simple questionnaires, and their history of exacerbations or flare-ups. So Group A is low symptoms, low risk. Group B is high symptoms but still low risk. But look at Group E. This is the game changer. A patient lands in Group E based only on their history of frequent or severe flare-ups, no matter how they feel day to day. Why? Because that history is the single best predictor we have of their future risk.
Okay, so we've got a diagnosis, we've categorized the patient. But why all the fuss? Why do we need to manage this so aggressively? This next section really explains what's at stake. What are we actually trying to prevent? Because the stakes are incredibly high. Those exacerbations we just talked about, they're not just bad days. They're like little earthquakes in the lungs. Each one can cause more permanent damage and speed up that long-term decline. They're also tied to a much, much higher risk of death. And, COPD doesn't live in a bubble. It dramatically increases the risk of heart attacks and other cardiovascular events. And in the late stages, it can cause high blood pressure in the lungs, something called pulmonary hypertension, which puts a huge strain on the heart. And that brings us to the main event, our biggest deep dive, the management blueprint. How do we actually treat stable COPD according to the gold standards? This is where everything we've talked about, the diagnosis, the assessment, it all comes together into one practical plan. When we think about treatment, we're always trying to do two things at once. It's a balancing act. Goal number one is to reduce symptoms. We want to make the patient feel better today, improve their breathing, and let them get back to their life. Goal number two is to reduce their future risk. We want to prevent those dangerous flare-ups, slow down the disease, and at the end of the day, help them live longer. Every single decision we make has to serve both of these goals. And this is where that ABE assessment really pays off, because the initial therapy maps directly onto it. It's so elegant. For a Group A patient, we start simple, just one bronchodilator. But for a more symptomatic Group B patient or that high-risk Group E patient, Gold says go straight to dual therapy. That means combining a long-acting beta agonist, a LABA, with a long-acting muscarinic antagonist, a LAMA. Think of it like this. You're using two different keys to unlock two different locks that are both keeping the airways clamped shut. Using them together gives you a much bigger effect than either one could on its own. But, and this is so important, treatment is not a one-and-done kind of thing. The real art of managing COPD is in the follow-up. We have to reassess the patient and manage them based on the problems that are still there, what Gold calls treatable traits. And the two main ones we're always looking for are persistent breathlessness, or dyspnea, and those recurring exacerbations. So let's play this out. Your patient comes back, and they're still breathless. What do? Well, the algorithm is super clear. If they're only on a single bronchodilator, the first move is always to step them up to that more powerful LABA/LAMA combo. But what if they're already on that dual therapy and still feeling breathless? We don't just throw more drugs at them. The guidelines make us stop and think. Is their inhaler technique any good? Would a different device work better for them? And critically, could there be something else causing their breathlessness? Now, for exacerbations, this is where it gets really cool. This is precision medicine in action. If your patient is on dual therapy and is still having flare-ups, we don't just guess what to do next. We use a biomarker. It all comes down to one simple blood test for a type of white blood cell called an eosinophil. If that count is high, 300 or more, that's a huge signal that this patient will get a major benefit from adding an inhaled corticosteroid, moving them to what we call triple therapy. If the count is low, a steroid is way less likely to help, so we look at other options like roflumilast or azithromycin. It's brilliant. Okay, we've talked a lot about inhalers, but I cannot stress this enough. They are only one piece of the puzzle. The Gold report makes it clear that these foundational therapies are just as critical, maybe even more so. Smoking cessation is number one with a bullet. It's the only thing that truly changes the long-term course of the disease. Vaccinations are a must to prevent the infections that trigger so many exacerbations. And pulmonary rehab, that's a structured program of exercise and education, is honestly one of the most effective treatments we have for making patients feel and function better. And for those patients with really advanced disease, we have some heavy-duty tools in our arsenal that go way beyond inhalers. Long-term oxygen is a proven lifesaver for patients whose blood oxygen levels are dangerously low. For very specific patients with emphysema, there are surgical options like lung volume reduction surgery or even newer, less invasive procedures using tiny valves placed in the airways. The idea is to isolate the most damaged parts of the lung so the healthier parts can work better. And of course, for the most severe cases, a lung transplant can still be an option.
You know, the GOLD 2025 report gives us this incredibly powerful, clear framework for care today. It uses these great tools like the ABE assessment and biomarkers like eosinophils to guide us. But it also gives us a peek into the future, a future where treatment might be even more precisely tailored to each person's unique biology. So it leaves us with this final thought. As our understanding gets deeper and deeper, are we going to move beyond even these elegant algorithms to a world of truly personalized prescriptions for managing this incredibly complex disease?